I'd like to thank AOS and Nirmal sir for this wonderful opportunity to talk on how to assess a patient plan for OP or daycare surgery. So the goals for pre-surgery evaluation mainly involves creating a rapport with the patient and their families and to ensure that their anxiety level is less and to reduce the morbidity of surgery to avoid surgical delays and case cancellation and to ensure that the patient is optimal at his prime medical condition is best for doing and going ahead with the surgery. Of course, last but not the least, we have to safeguard us and ensure that we are safe. So who is fit for daycare surgery? Well, this was an article which I went through the Indian Journal of Anesthesiology 2007. They say that a patient can be considered as healthy who comes under the clause 1 and 2 by the ASA guidelines. So what is this ASA guidelines? This involves a normal healthy patient as well as a patient with mild systemic disease. These two are patients who can be comfortably taken up for daycare surgery. Age is not a considering factor. We should not consider age as an absolute guideline for considering a patient to be perfectly fit. However, a patient more than 80 years of age can be considered with increased perioperative risk of developing complication. And of course, body mass index is something that is very important that needs to be considered. A patient in general with a body mass index of less than 40 kg per m square can be considered as medically fit as long as his other comorbid conditions are well under control. Patients with BMI of more than 50 are generally considered at higher risk of developing complications. Those between 40 to 50 are in a relative gray area. They should be taken with a case-to-case basis. Preoperative assessment involves a detailed history from the patient, doing a proper general examination other than ocular, systemic examination of specific systems if needed, laboratory investigations, which is important, expert opinion from specialists if needed, a proper anesthetist and a surgical consent is mandatory. With regards to COVID, which all of us are interested on in today's world, this is a guideline again given by the American Society of Anesthesiologists published in December 2020. Any patient who's had mild COVID with no respiratory symptoms and who has recovered well, they can be taken up 4 weeks later for an elective surgery, 6 weeks for a patient who's been symptomatic, that is mild symptoms, and who has recovered at homes. 8 to 10 weeks for a patient who's been symptomatic and he's having other comorbid conditions like diabetes or immunocompromised patient or a patient who's been hospitalized. Any patient who's recovered in the ICU and was sick will need a time gap of about 12 weeks. Well, why all this 4 weeks, 6 weeks, 8 weeks, and 12 weeks? This is mainly taken into consideration that majority of COVID patients can develop thromboembolic complications. And this waiting time is mainly to ensure that that risk factor window is crossed and we can do the surgery comfortably for the patient. This is to safeguard the patient as well as to ensure that we don't encounter these things. Like for example, after a simple cataract surgery, the patient may go home and the next day if they develop maybe a stroke or an MI, they will immediately blame it on the cataract surgery. If we do it within this window period and medico-legally also, we may be in trouble. So this has to be taken into consideration so that medico-legally as well as ethically, we are right as far as the patient is concerned. With regards to history, a detailed history needs to be taken explaining the current symptoms, if there are any, history of comorbid conditions, mainly the common ones which we encounter include diabetes, systemic hypertension, lung disorders, seizure diseases, cardiovascular diseases, and thyroid disorders. Effort tolerance is a common name or is a common fancy term that is used by anesthetists in today's world. This is a simple term which means that a patient is able to do his routine day-to-day activities, maybe climb a flight of stairs and is comfortable. Previous hospitalization and surgery history also needs to be taken. History of allergies, as Nirmal sir wonderfully told in the previous talk. Medication history again is of prime importance when considering daycare surgeries. What we commonly come across include blood thinners, inhalers, steroid usage, and anxiolytic. That is mainly patients with ischemic heart diseases, lung diseases, or patients on chronic steroids and patients on anxiolytics. These are common drugs which most of our patients are on. When to stop or to restart blood thinners is $1 million question. In general, warfarin, it's better to stop 5 days prior to surgery. We have seen in many places where warfarin is stopped for a day or two, it really doesn't make sense. If warfarin has to be stopped, it has to be stopped at 5 days prior to surgery. With regards to antiplatelets, mainly aspirin, if the patient has a high cardiovascular risk, it's ideal to stop. It is ideal to stop. If a low cardiovascular risk, it is better to stop. If the patient has high cardiovascular risk, we can continue with the drug. If the patient is on clopidogrel, again like warfarin, it has to be stopped 5 days prior to surgery. Well, most of us do clear corneal surgeries. When it comes to cataract, we may say there is no need to stop. But then if block is given or if we encounter an expulsive, we may get into trouble. So it's always better to get a physician to analyze our patient and then take a call with regards to blood thinners. With regards to restarting, if the patient has a high risk of bleeding, it's better to restart within 2 to 3 days after the procedure is over. General examination, assess the patient as a whole. Check the general condition of the patient, check the consciousness level, orientation, hydration, and pickle, which we are fond of. Tyler, icterus, cyanosis, clubbing, pedal edema is very important. Systemic examination, a proper CBS examination by a trained physician to check for heart sounds, murmurs, if there are any, respiratory system analysis, checking the breath sounds, if there are any added sounds, again needs to be evaluated. Abdominal examination, including genital examination, needs to be done, and a proper thorough CNS examination also. Lab investigations, mandatory examination includes maybe a hemoglobin, total differential count, blood sugar examination, serum creatinine and urea, because most of us give NSAIDs post-cataract surgery, ECG to assess the general condition of the heart, chest X-ray today as a routine we do for most of our patients because this gives an idea about the patient's well-being in this COVID scenario. As Nirmal sir said, checking the SpO2 again is of prime importance in today's world. Echo can be done for patients who are at risk. If we are anticipating blood loss like cases, orbital surgeries or DCRs, coagulation profile also needs to be done. Serology again is mandatory considering the safety of our team and us. So how expensive are these tests? Well, a baseline tests, what we discussed previously, will hardly cost the patient around 1,300 to 1,500 with a nominal profit margin. If we don't want that profit, we will be hardly making the patient spend around 900 to 1,000 rupees, which I feel is personally worth it considering our peace of mind. Expert opinion, if needed, has to be taken from cardiologists, pulmonologists, endocrinologists, or anesthesiologists if needed. Consent, again in today's world, separate consent has to be taken for anesthetist as well as the surgery. One consent form having both is not appreciated in today's world. Both has to be separate. Well, this is something which we follow in our center, a preoperative checklist seen by the physician with a quick tick marks for them so that it is easy for them. We get a physician clearance prior to any daycare surgical procedure that we do. Getting a physician to assess our patient and to give clearance is very, very important in today's world. There is a myth or a fear that we may lose the patient in case we suggest the patient to take a physician opinion. This can be comfortably overcome by counseling our patients, maybe spending the extra 1 or 2 minutes with us and maybe extra 3 to 4 minutes with our counselor. This will save hours and lakhs of rupees that we may have to waste post-surgery in case we get into a grave situation. It is always better to do what we know best. It is advisable to be a king in ophthalmology and live life king size rather than to become a jack in anesthesiology also and be a laughing stock in case we have an issue. So let's stick to what we know best. Physician and anesthetists are our saviors and our patient saviors. It is a myth that they cancel cases. They don't do it intentionally. they do it if need be. So again, I would like to thank AOS, Partha sir and Nirmal sir for this wonderful opportunity. Thank you, sir.